All right. Now, she has a client where the tendinitis manifests more in the actual patellar tendon. Now, if you're being a real stickler in defining these two things, superior to the patella is a tendon because it's muscle to bone. If I'm being real snarky, I get to go the lower portion, the patella to the tibial tuberosity, that's a ligament. And it's a bone to a bone. But nobody cares. They all call it a tendon. And most people will get patellar tendinitis inferior to the patella. It'll be like lower, kind of underneath, and it may be a little bit more medial versus lateral. The tendency is for it to get more irritated on the medial sides of things. Her client, it tends to be a little further up and tracks medial, all of that. So what to do there. This also will correlate with just a good thing to do for other tendinitises that can manifest, whether it be that pes anserine, which crosses right over the medial line of the knee. And so you won't sometimes know, did they find a way to irritate the MCL or have like a mild sprain of that somehow versus that attention. If it is this one, it's down here on the tibia where that attaches. I showed you on that muscle model where that is. Versus the fibular head over here. There we go. Is where the hamstrings also attach. If you get into a territory of trying to figure out things with the patella in a generic sense, for beginners figuring this out, just ideally it should move, relaxed here, should move relatively uniform side to side. It should feel like you can make it go up and down. Like here feels actually maybe a little tight, up and down, which would fit. A lot of people have tight hip flexors, something, and that can be affecting there. From a massage standpoint, your best initial tactic for addressing this is not to work too aggressively here, but to really get all of this stuff. Get the adductors like crazy, get the hamstrings really good, get the quads really good, hip flexors, make sure you're addressing even here because that could be affecting the fibula. Better to just, because if this is being pulled taut, right, by the muscles up here, we want to address that so everything loosens down. Now, from a firing pattern standpoint, the activation sequence of the quadriceps muscles, ideally vastus medialis is dominant and lateralis is less dominant. And from a symptom management standpoint, this will work really well for you because people with tight IT bands or patellar knee-related symptoms, if you want a quick, always go-to, can always be beneficial option, it's inhibit lateralis, so just squash inhibitory pressure, and then the action at the knee I want is not this one, where they just kick out like this. I don't want to replicate necessarily the gait action of kicking your leg out to walk. I want to replicate a person standing up out of gravity. So she's going to keep her heel down and push the back of her knee down into the bolster and flatten it out that way. There we go. So it's more like you're standing up rather than walking. And that puts more stress on the knee. So I'm going to get stuff to activate here more, all that. So from a massage tactic for all kinds of knee stuff, good inhibitory pressure. And if I'm going to use things like depultment, even vibration to kind of send a signal to wake up, that's where like a little tap or a little just, yeah. Inhibitory pressure, a little contact, and I go, okay, flatten your knee a little bit. Like right here. Good. Hold. And slowly back down, nice and easy. And then again. Okay, good, back down. And that would be just a tactic for you to consider, because maybe if his VMO were firing better,
right,
that irritation wouldn't be as likely.
If they have hypermobility in the knee, is that still fine?
Yes, because you're not creating, you're not lengthening ligamental structures or taking it in a stretch. If they have hypermobility in the knee, I want to go into like a straight leg stretch, or be like turn them over and prone and be trying to like crank. Here, at least, what we're dealing with is actually creating more tone on medialis, which is more about stabilizing and making sure that patella tracks correctly. So now, even with them, it can be a for sure safe go-to. All right, this one should be the first one. So right over the tibial tuberosity. And this is one where I can grab both anchors, just stretch right over top. Then down and down. Then we should have done the green ones. And up here, we're gonna have another one. So let's keep going. Let's go ahead and just take these off. We're gonna redo these.
Just redo this.
Yeah, let's go and start this over. But there was our first one. Ha. Then we're gonna do our other half bracket. Now here, I kind of picked generally where that is.
Yeah.
Again, be a little bit careful being too close because the patella is gonna go up. It's not gonna come down. And the only thing about this aesthetically that it will do is it will bunch the skin here. And sometimes it will look a little odd on some people that suddenly there's this crazy bunch of skin once they stand up and everything comes back to flush. So let's say somewhere around there.
Yeah, that's
Okay.
where it is. Yeah. So actually, like right on where he's.
Yep.
Okay.
So brackets across. So that would be in real time, me realizing I made a mistake and kind of going, you know what? It should have been this way. But I sacrificed a couple pieces of tape. Do that. Then we'll. Maybe I could have pulled those up and got it to go down again, but whatever.
70 cents worth.
If I did the full math on it, somebody could break that down. What's 16? What was it? 16 feet?
16 feet.
16 feet divided by
Heavy tape is about
17
bucks.
bucks.
So it's about $1
$1 a foot.
$1 a foot. So yeah, you're spending $1 on each one of these. So I think it used to be less, to be honest. When I first was buying these, they were more like $8.
Oh yeah, actually when I first started using rock tape, it was like $8.
Yeah. So inflation. All right, go ahead and bend a little bit. All right, go across the straight line. See how much better that's all going to be. Okay, and down.
So taping my son's knee, I should also tape below it as well.
Yeah, wait, if you want to cover all bases,
Okay.
probably wouldn't be necessary. So no, you could just do these three.
Okay.
Someone that has issues with patellar dislocation, would the 4 pieces be the best way?
The patellar dislocation people is where I get way more cautious here.
Yeah.
I would be,
Would you just do the sides, or would you still do that above and below?
I would pick one. I would pick.
One or the
I think
other.
I'd pick 2 or 2
Okay.
to start. Just as if I'm making a recommendation, if that thing is already so slippy slidey, I'd be like, try above and below.
See what
Try
happens,
side
and
to
then try
side.
side to side.
But yeah, and just see how they respond, and just make sure they are not a crazy person, and they are a good like self-reporter.
Yeah.
And all of that.
How long would you say they need to say they're feeling okay about it? Is it a couple minutes, a couple hours?
They should. Oh yeah, it should feel like it's at least safe within like the first day. You know, like even once they're up moving around, you usually get a pretty immediate like sense of feedback with this stuff. So there, I'm not usually too worried. Come down. Don't want to go over. That'll be fine. But yeah, so there's the adjustment. Better to do the horizontal ones first, and have that go over top, and then that's all just going to hold itself down real nicely. But those, and then once she stands up, you're going to see that it's going to probably want to like group together. But it's going to be a case where just more often that when they're laying with the bolster underneath, it should feel like the patella has room on either side. If that tape is sitting on the patella, then I just preach a little bit of extra caution, you know, especially if you've put a lot of tension on it. But that really covers almost all your bases there.
Yeah.
You know, that you could make an argument here, let's say it's more about hamstrings. Like I could have taped on the fibular head and tried to go more posterior up here, I could do this for the hamstrings because that's the actual hamstring attachments. It would be fibular head for bicep femoris. And then for semitendinosus, not so much membranosus, but same thing. So I could tape anterior, go posterior, and then do bracket across, bracket across. And it
Do
just,
that for what? Say that again.
let's say I seen that their issues are more related to hamstrings.
Oh.
So if, for whatever reason, it was more hamstring issues. So usually we can do a good job mobilizing hamstrings and gastroc, and they need some kind of counter irritation over here. And if the tape is helping with that somatosensory, like giving them a little bit extra information, I want them to be stronger in their knee extensors. We usually are too strong on knee flexors versus extensors. So typically this is the right way to tape for most knee issues. But you get somebody that the symptoms run in a different orientation, then just start following that anatomy.